Good morning, and thank you very much for the opportunity to give you this update. And indeed, I'm delighted that I will be co-presenting with Aldo and Elizabeth, who both are members of the Darwin EU Advisory Board. In our brief update, we'd like to tell you about the progress of the establishment of Darwin EU, the ongoing pilots of use of real-world evidence with the EMA's committees, and the currently ongoing real-world evidence studies at the agency. We would then also talk about the criteria for the prioritization of data partners to be onboarded into Darwin EU, a brief note on the data protection impact assessment, and the next steps. So next slide, please. In the previous update we gave to the working parties in March, we spoke about the selection of the coordination center and our immediate next steps in project management. So if we focus now on the timeline, which is denoted by the green line at the top right hand. So from February, we started working with the coordination center, and we have already initiated the work on the data protection impact assessment, which I will tell you more about. And we have intensely worked on the prioritization and selection of the first data partners, which would then allow us to perform the first studies. So in June, we expect to start the onboarding process, having had a very fruitful discussion, and we will come to the criteria just in a minute. And we've also had a discussion with the Coordination Center of Darwin EU about what the likely studies would be in the first phase. And we hope to be initiating those in the sort of warmer summer months, July or August, and run those until the end of the year. Next slide then, please. So in the use of real-world evidence by EMA's committees, we are already in a routine support of the PRAC with real-world evidence studies. We had a very successful pilot in the last 2 years, and we implemented the lessons learned and are now routinely screening the PRAC agendas for potential research questions. We are also working in a pilot with the Scientific Advice Working Party and with the Orphan Committee, Pediatric Committee, and the Advanced Therapies Committees. We are currently in very close talks with the CHMP on initiating the pilot for the Human Medicines Committee, and in fact, we would be having another meeting with the CHMP next week, which will likely mark the start of the pilot, and I have another more detailed slide coming up. We've had a number of discussions with the other stakeholders, such as the Coordination Group for Mutual Recognition, CMDH, and the representations of the NCAs on how we could support the use cases coming from the national assessment work. And also we are in talks with the representations of the health technology assessment bodies and payers through the Darwin EU Advisory Board, and we are planning further close cooperation with them through a workshop later this year to define a use case we could pilot for the stakeholders involved in HTAs and payers decision making. Equally, we also proposed a use case for the pilot of the European health data space, and as that's developing, we would hope to run one of those use cases later this year or next year. Next slide then, please. So in terms of the demand for the analyses through the 3 available routes for real-world evidence at the EMA, since we started with this current pilot with all the committees in October 2021, we've had excellent engagement, and we've had a number of 34 research requests for initiating studies. 16 of those were feasible and mostly completed within very short timelines. I think the median time was 9 or 10 days from request to results. And a number of the studies are still in the feasibility assessment step, that's the middle of the slide, and 10 of the requests were not feasible, and we're perhaps not surprised to find that, because in our previous work with the PRAC, we also found that the currently available data sources to the EMA, that's not to the Darwin EU, but to the EMA, were mostly primary care databases, and therefore the exposure of some of the medicines, the more advanced therapies or medicines given in a secondary setting only with pre-medication or infusion route of administration would not be captured in these settings. And this is another of the reasons for Darwin EU, where we can capture broader data sources and really look at all the medicines uses and therefore the safety and effectiveness. So we are very positive with the demand we see with the committees. And on the next slide, I can also tell you about what the nature of the studies is. So mostly the studies requested are on matters relating to safety. The color split on this slide is just technical for us. It's whether we have offered this study from our proactive screening of the committee's agenda or whether this was requested by the committee members themselves. So safety studies relating to the work with PRAC, with whom we have worked for the longest. Then the second most common type of analysis is disease epidemiology studies, and this relating to our work with the COMP, for example, and further drug utilization studies, informing design and feasibility of the planned studies in pre-authorization or at authorization, clinical management of a disease, and looking at the impact of regulatory actions. These use cases and types of analyses are very much in line with what we had previously foreseen, and we expect that to evolve as we have more and more requests from all the other committees, and indeed from the CHMP. If we go one slide forward, then on the CHMP pilot, which we would like to initiate in June or in July, our aim is to inform of all the real-world evidence initiatives at the EMA. And if I may remind you, we do have access to some databases in-house. These were traditionally primary care databases. We are now adding also some secondary care, some hospital care data to those. We also have contracts with external providers through which we can procure studies through the data sources which they have available, be it academic research institutions or other. And then starting this year, and we are very excited to have the extra capacity and the capability through DARWIN EU. So we will be talking with the committee members and assessors about the practical aspects of the pilot, discussing the use cases and the points in the assessment procedures at which analysis can be requested, turnaround times, and any practical details such as feasibility assessments, protocol content, etc. So we are now at the pilot outline discussions with the CHMP, consulting on the exact scope and some of the practical details, and hoping to start the pilot this month or early next month, running the pilot probably for 1 year or 1 year and a half, with a mid-pilot evaluation after 6 to 9 months to identify what are the most common use cases, are they well served with the data sources we have currently, to also inform the selection of data sources in future phases. And from our discussions with the committee, we expect that the most likely use cases would include the supporting the planning and validity of applicant studies, informing about sample size calculations and the availability of patients with particular characteristics. Also looking at validating completed trials, whether the populations are indeed representative of who is the target indication for a new application. Understanding the clinical context, so understanding the disease epidemiology and the treatment patterns in a particular disease. Many disease areas are rapidly evolving with new products available, and rapidly transforming the survival and the outcomes of patients. So this is really important. And lastly, studies to investigate the associations and impact. And if we go one forward, and I would like to pass over to Aldo now to discuss with you the criteria for prioritization of data partners into DARWIN EU. Thank you very much, Aldo.
Many thanks. Good morning to all of you. Using a couple of slides, I show you the criteria for prioritization of the new data partners. This slide shows the primary criteria. The primary criteria is continuous data collection with at least an yearly update, and very important, an ideal lag time between data capture and data availability of 6 months or less. This is really a problem for some data collection to have this kind of timing in the availability. The other criteria is health outcome and medicine prescribed that are easy identifiable with a linkage to individual patient, a unique identifier. Then a well-defined underlying population with entry and exit dates, and data sources in which patient can be registered with different identifier to be clearly identified. Another criteria is to have care setting appropriate for research question and not adequately represented by other databases, such as database of primary and specialist care or inpatient hospital care, or data sourcing measuring indication, dose, and duration of treatment. Regarding the geographical spread, it is important that the data base covers EU country not adequately represented by other data sources, it is necessary to have a documented experience in collaborative studies and to have the possibility to convert into common data model with appropriate validation and testing. A technical criteria, it is important to have an adequate and transparent governance allowing a peer review of quality management processes and to have an adequate infrastructure allowing a secure transfer of results. Next slide, please. And these are the secondary criteria supported by the advisory board of Darwin EU. It is possible to have non-EU data sources if they significantly can contribute to research questions raised by the EMA committees. This can be quite important, for example, for rare diseases or, for example, ethnic differences in the effect of drugs. The second criteria database, which provides linkage and continuous follow-up between primary and secondary care, database with mother and child linkage, information on dispensed medicine, and possibly larger sample size. For example, the number of active patients, and database is not converted or partially converted using the observational medical outcome partnership data model with potential for significant contribution to research questions raised by the different EMA committees. I will leave the floor to the following presentation.
Thank you for listening to this, the onboarding of the data partners and first studies. So the data partners we are currently looking at are on primary care, on specialist care, and hospital care from e-health records. And it's good to say that it is including ambulatory and inpatient data. And the claims of the claims databases, the disease registries, if applicable for a certain disease, the drug prescription dispensing or other utilization, and then the patient reported outcomes. And as at the end, in drug approval, but also HTA, it's important to know what a drug really means to a patient. This is a relevant data collection, and we plan to organize a meeting on patient-reported outcomes, or in the context of this project, I think it will be used patient experience data in later this year. It was initially announced for Q2, but that's gone now, so it will be later this year. So initially 10 partners to be onboarded, and the first pilot studies in 2022 for a number of use cases across the medical product life cycle. And by 2025, we expect to have more than 100 studies per year will be conducted. Thank you. Back to Andre.
Thank you very much, Aldo, and thank you, Elizabeth. Before we can make use of any of the data that the data partners will bring into the network, of course, we are executing the data protection impact assessment and looking at the data use agreement template that will be signed with the data partners. Here we're looking for data protection by design, and in the federated model where data stays local and only aggregated results are shared back to the coordination center, this should very much facilitate that, and the data is already anonymized. So we're looking for robust data protection safeguards, and this is, of course, a legislative requirement for data protection impact assessment. We have performed a preliminary DPIA during the selection process for the provider of the coordination center services. So the current DPIA is building on that and looking at more particular and concrete examples of data processing through the future analysis via Darwin EU, such that by the time it's finalized, we are ready, we are aware of the risks and can onboard data partners and perform analyses. So the DPI aims to assess any data processing which will be performed, to describe the nature, scope, context, and purpose, assess the proportionality and whether this is really justified, and at the same time identifies any risks and puts in place the controls which would mitigate those risks. So as part of the DPIA, they would be also looking at the draft data use agreement with the data partners, because this expects to be managing data protection by all the parties, so to have clarity on roles, what is the responsibility of the data partner, the coordination center, etc. So I think I only have one more slide if we go forward. The next steps for Darwin EU are then finalizing the data protection impact assessment, where we hope to do it at the end of this month. We are in parallel reviewing the deliverables from the Coordination Center for the milestone 1, which was due by the end of the 3rd month. And we are currently reviewing the last one, I can tell you. We would then be looking at the data use agreement template and the study template, such as the feasibility, study protocol, study outline, and study report. We are finalizing the selection of the data partners, and we'll proceed then to the onboarding. And I can tell you, I can't quite show you the list yet, but I can tell you that we have actually very good representation among the 10 data sources which we are aiming for, which come from 8 European countries spanning East, West, North and South Europe. And we are very, very pleased to see also quite a number of secondary care data sources among those which we were previously missing. We are also in discussions with the Coordination Center whether we could be increasing the number of the data partners or proceeding to the next phase to onboard the next 10 data partners a bit earlier. So watch this space. Once we have the data partners in, we would then start with the first pilot studies and therefore realize the first benefits of the network and for the stakeholders. And in the future, we also expect that there would be direct open calls for data partners who could then be onboarded into the network. On the last slide, I would just thank you for your attention. The more information on Darwin EU is available through the link. In February, we held a webinar, which is recorded, and the recording and presentation are available if you'd like to know more, in particular over the technical detail. And as Peter said in his earlier presentation, the Big Data Highlights newsletter is now out in its 2nd form, which also gives you more information. Thank you very much. And thank you again to Aldo and Elizabeth.